Thank you, Dr. Talwar, sir. Now, may I request Dr. Himanshu Mehta now to present his experience of anti-VEGF in a PDR management. Talwar,
Thank you,
sir.
Dr. Prashant.
Talwar, sir.
Good afternoon, friends. Just to let you know that there is no financial interest in this particular medication or any other of these pharma products from this company. I wish I had any, and I wish you all too had any, because this is a growing market, it's here to stay, and it's effective. It's not just marketing. So remember that Richard Bach statement, that there is no such thing as a problem without a gift for us in its hands. We seek problems because we need those gifts. And here it is, the role of anti-VEGF in PDR management. It's a very important thing. As you know, Dr. Talwar has managed to say a lot of good things. I will make it a lot brief for you so that I don't come in between your lunch and you. Just to mention a few basic things on etiopathogenesis of where we start, and that will make life a little easier, why you should be using it. The hyperglycemic factor and the biochemical reaction, the molecular which happens, the hexosamine pathway and the polyol pathway, the VEGF factor and the ANG2, you can realize these are things which are really changing. The understanding of the subject changed when we started. When we started practice, way back, we had nothing to offer to these patients, diabetics and or ARMD or BRVO. Macular edema, you couldn't go close, you couldn't do a grid, you could permanently destroy. The revolutionary treatment which came was once you had the anti-VEGF coming into the picture. So there is endothelial parasite loss and thickening of the basement membrane and leukocytosis, giving you macro and microvascular complication. The whole story is ischemia, ischemia, and ischemia. And the body is very smart. It wants to give it more blood. So when there is hypoxia, there is a stimulus of VEGF and neovascular formation. So the clinical features would be non-proliferative diabetic retinopathy, mild, moderate, severe, which you are aware of, that you have only microaneurysms, the intraretinal microvascular abnormalities, the ARMAs, and when widespread intraretinal hemorrhages and microaneurysms observed, these are the severe cases. Whereas the proliferative one, now quite often the patient directly comes with that because one eye was seeing well, and most often than not, they come like that. One eye was seeing well, so they never bothered closing their eyes, and we have PDR in one eye and a non-PDR in the other eye, characterized by retinal neovascularization, new blood vessels, they are likely to be fragile, and that is what the most important thing. And the worst scenario, as I give it to the patients, that it's like your Wankhede Stadium or the Firoz Shah Kotla Stadium. The stadium is okay, but the pitch is destroyed. In diabetic macular edema, it can occur with any diabetic retinopathy, but most likely to manifest following non-proliferative diabetic retinopathy. So what are the clinical features? The 50% of people with severe NPDR progress to proliferative within 1 year. So remember that, 50%, not a small percentage. And you know what is the kind of population with the Pizza Huts and all that we are going to be getting? India will become the diabetes capital of the world. Novartis shelled off its pharma division to JB, but they have not given off this. Why? Because this is the real egg which will lay the golden eggs for them. And so within what you can see, 50% getting NPDR to PDR, and within 1 year, and 25% of patients have PDR at least 15 years of diabetes duration, which means when I see some of these 20, 25-year-old diabetics without any diabetic retinopathy, I say your name has to go into the Guinness book. There is some gene which is protecting them. And there are these some 30-ish kind of people, 30, 35, terrible diabetes, and they have bleeding in both the eyes, and they're terrible. So we are not looked at that as yet, but that's something very important. So you have vitreous hemorrhage, you have fibrosis, you have vitreous or retinal detachment, and vision loss can occur as the diabetic retinopathy worsens from NPDR to PDR. Of course, that's the time they come to you. As the diabetic retinopathy progresses, abnormal blood vessels grow, mediated by the VEGF occurs, and the new vessels are fragile and prone to hemorrhages, disruption vision, and causing scarring. Patients with PDR experience those spots in their field. They would say they are seeing something less, they are not very clear about the whole thing, but they don't know the severity of the whole thing. PDR is associated with high risk of visual morbidity arising from tractional retinal detachment. You will see small areas. Once fibrosis starts, small areas of tractional retinal detachments are there at the periphery when you are doing a B scan. And the problem is the patient doesn't understand the gravity of the situation, that how bad are they and where are they progressing. The eye really looks like on fire. Current unmet need and role of anti-VEGF in PDR. Of course, 40% of proliferative diabetic retinopathy do not respond to PRP treatment. One-third of the patients have recurrence of neovessels within 1 month of PRP, and PRP takes 3 months for complete regression. Whereas 4x increase for the vitrectomy compared to anti-VEGF, of course, when the moment you get that, there are high chances that you'll have to do vitrectomy and membrane peeling and the rest of the stuff. So PRP does not improve visual acuity, and vitreous surgery can lead to infection, all the problem that you can have. However, the role of VEGF throughout the spectrum of diabetic retinopathy provides a strong rationale for the use of anti-VEGF agents because the potential to prevent onset and recurrence of vision-threatening complications of diabetic retinopathy. Anti-VEGFs in PDR, there is a lot of evidence to suggest that. There is no question, everybody is convinced beyond doubt. When it came into the market, it was very difficult to believe that you have something which can not just protect your vision, but improve 1 or 2 lines. It was very difficult to digest at that time, that whether it was a marketing strategy by the company or whatever. But the fact is, all of us have seen it in our practice, that the moment you start, even a worst case of fibrotic, bleeding, vitreous hemorrhage, tractional retinal detachment, and proliferative diabetic retinopathy, the moment you've given a couple of injections, the eye really looks quiet. It stops progressing. You don't even have to do too much laser because the moment you do more laser, there'll be tractional retinal detachment happening further. So the study population which was there was 394 patients with PDR with or without DME, and the primary outcome measures was mean visual acuity changes after 5 years. Conclusion, they found that support either ranibizumab or PRP as a viable treatment for patients with PDR, and better visual outcome achievements with ranibizumab monotherapy in eyes with or without diabetic macular edema. There is no question about it that monotherapy, just plain without permanently damaging, scarring the retina, that can still work very well. So the RISE and the RIGHT study to evaluate the diabetic retinopathy outcomes with ranibizumab treatment in patients with diabetic retinopathy and diabetic macular edema at a high-risk progression to proliferative disease. The study population was 746 patients with baseline fundus, more than or equal to 2 steps or more than equal to 3 steps improvement or worsening of the ETDRS. Remember the ETDRS study, the good old one, the DRSS and time to new proliferative events. So the conclusion there was intravitreal ranibizumab reduced the risk of diabetic retinopathy progression. So diabetic retinopathy improvements were rapid, clinically meaningful, and sustained through month 36. As Dr. Talwar mentioned in his talk, time and again he mentioned how don't give up hope, start from the beginning. If you have a long time gap, like he said in the last patient which he mentioned, forget it that the past treatment was history. The company benefited, the patient did not benefit. It's an ongoing process. From day one, we have to explain to the patient that it's not a one-shot therapy. It's not like tetanus that 3 injection ho gaya, finish ho gaya baat. This is ongoing, something which is very difficult for patients to digest. So if I have to give you the answer, what I have to tell them is that it's like this, that Kasab came, Faisal came or Afzal came, they were destroyed, those terrorists were destroyed. But do you think somebody else can come still and do some terrorist masti in this country? Surely. Why? Because terrorism persists. So why did you take the injections? Believe me, most of them don't have the answer. Few of them come and tell you, yeah, it is possibly diabetes ki wajah se hua tha. So the moment you tell them and associate that it was diabetes responsible for this, and say, has your diabetes gone? No. So you will need it. That is what is required for your treatment. So the RISE patients with more than 2-step improvement, as you can see in front of you, the sham study, the ranibizumab 0.5 milligram crossover, you can see the arrow will go up, no question, and ranibizumab treatment reduced the time to new PDR event in patients with DRSS 47 to 53 at baseline. I won't go into the graph further, but just to give you the baseline understanding, the protocol 1 evaluate effects of the intravitreal ranibizumab or triamcinolone administered to treat DME or worsening of, as Dr. Talwar mentioned again, that you may also have to give triamcinolone, some steroid to reduce the inflammation. And that synergistic effect can really work very well when it's recalcitrant. Diabetic macular edema is your most recalcitrant treatment. This may work, that may work, this may work. You don't know which one will work. And you don't even know whether each one of them will work. So you can never promise. It has a mind of its own. So you will have to try various strategies, and you'll have to tell them from the beginning. So the study population, which was 538 eyes without PDR and 254 with PDR, 3-year cumulative probabilities for retinopathy worsening, primary outcome measure. And the conclusion was intravitreal ranibizumab appears to be associated with a reduced risk of diabetic retinopathy worsening in eyes with or without PDR. As you can see again, ranibizumab treatment is associated with a reduced risk of diabetic retinopathy worsening in eyes with or without PDR. You can see that very clearly here. Eyes without PDR at baseline and eyes with PDR at baseline. So treatment associated with ranibizumab definitely reduces the risk for diabetic retinopathy worsening, and we are all witness to it. To assess the efficacy and safety of ranibizumab with or without PRP compared to PRP alone in patients with PDR. So the population here was 106 patients, change in area of retinal neovascularization. Let me go to the conclusion. Ranibizumab showed stronger effects on neovascularization and leakage and areas of reduction while offering better visual acuity. This is the most important thing, is to save the pitch. Save the macula till the last day as much as we can. Results rather than PRP alone. So earlier it was PRP, PRP, PRP. From there it came to co-sharing, and now I would lay little more stress on anti-VEGFs and less on the laser burning of the retina. So superior outcome, mean changes in neovascularization area in the combination group compared to PRP alone. No question, at month 3, a combination of ranibizumab plus PRP was significantly more effective than the other, and pronounced improvement of the morphological parameters in the combination group compared to PRP alone. Strategies, well, what are the strategies for combination therapy? Anti-VEGF or PRP, what comes first? So in the study and the outcome which was done, the conclusion was clear that ranibizumab plus group showed clear advantage over that in the PRP plus group in the treatment of PDR. As I was mentioning, as we saw what the previous speaker also said, that no doubt about it that your PRP reduces, the results are much better. You start with the ranibizumab injection, anti-VEGF first, and then go on to your PRP later. A couple of cases that you can see, look at the edema and look at the post-injection. These are cases where you will see the edema there and recurrence of diabetic macular edema. Steroid responses also noted after second dose of intravitreal triamcinolone. Focal lasers were not considered as the FAZ, the foveal avascular zone was enlarged and distorted. As seen here, once you start giving the injection, it definitely gives rise to reduction in edema. And the clinical scenarios for anti-VEGF combination therapy in PDR management. PDR with DME, as per protocol S treatment with ranibizumab, reduce the risk of DME development, and there is wealth of data to support that anti-VEGF use in DME. PDR with no traction and patient with good compliance. This is the most important thing. How do we make the patient understand the importance of multiple injections, the economic warfare which is there, the relatives, and the dirty disease called diabetes, which is also affecting their kidney, their heart, their brain. By the time your treatment is going for 36 months to 4, 5, 6 years, quite a few of them have had a bypass, quite a few of them have had a kidney problem. So there are comorbidities which are going on simultaneously. So PDR with no traction in patient with good compliance. Prior study showed that better neovascularization regression and meaningful visual acuity and outcomes. So PDR with NVI, in case of poor regression with PRP, anti-VEGF can be considered as per the study treatment with anti-VEGF, resulted in complete regression at 6 weeks. So this is something important. So summary, diabetic retinopathy is emerging as a significant health problem. We are going towards 100 million diabetic patients in this country very shortly in the next decade, less than a decade. So PRP was a standard care, but have a high risk of tractional retinal detachment, hemorrhages, and visual field loss. Anti-VEGF, if I have to ask, how many of you would prefer anti-VEGF in your eye compared to a PRP? Would anybody like to answer that question? Would you prefer a PRP or would you prefer an anti-VEGF? Yeah, I think it's a no-brainer whatsoever. So anti-VEGF induce regression of diabetic retinopathy in most patients, protocol S, right protocol. We have enough evidence to say that. And anti-VEGF in combination with PRP may be considered in following clinical conditions. PDR with DME, PDR with no traction in patient with good compliance, and PDR with neovascularization. Active PDR after complete PRP and PDR with vitreous hemorrhage also, which means essentially any diabetic at any stage, when you also feel. One more thing that I would say is even if one eye, as sir was saying, that the vision is 6, I would say even if the vision is 660 and less in one eye and the other eye is good, don't miss out treating the bad eye. You never know which one will become good in the long run after 5 years. The good eye may become worse in a few years, and the bad eye might be the one which is seeing. So don't give up hopes. Do give your treatment. It's the best shot that we can give to save whatever treatment we can. Ranibizumab followed by PRP results in better clinical outcomes than PRP followed by ranibizumab. Thank you so much for your time.
So let us, the few take-home messages from the talk is, actually laser is a destructive treatment. It causes a lot of problems. That is why we are trying to reduce the laser. But in spite of that, laser is one of the first-line treatment in PDR, and anti-VEGF cannot be taken as a monotherapy in Indian patients at least, because the follow-up is extremely important. Even in protocol as 5-year follow-up, those who missing follow-up, they are disastrous. So anti-VEGF alone in a PDR is not a probable solution in India at least. So laser still holds, but we want to reduce the laser because it is a destructive treatment, and then we use this as a combination. That is what we all practice now. Yeah. So probably there are some specific indications where we use anti-VEGF before or after laser, before surgery.
Yeah, basically the use of anti-VEGF as an adjunct to laser ensures that your regression of neovascularization is better, quicker, and more complete. You have kind of highlighted as to where you would certainly use anti-VEGF in addition to your laser, and in that you have mentioned patients with PDR with NVI, patients with PDR with CI, centrally involved diabetic macular edema. You have mentioned, I'm just repeating it for the audience again, PDR with vitreous hemorrhages. But with that, I think we can also add PDRs with high-risk characteristics, because there also you don't want the disease to take a chance, and you want a quick regression of the neovascularization. So that also could be an added indication. And also you have mentioned that where the PRP has as such not led to a complete regression, obviously there also you need anti-VEGF.
I think it's important that the take-home message should be very clear. Anti-VEGF monotherapy can be given, but it's like catching the tiger by the tail. Once you've caught it, you can't leave it. If you start the patient on anti-VEGF treatment, monthly follow-ups are necessary. Treatment is needed every month or two. On an average, a patient who has, say, diabetic macular edema with PDR will require 14 injections over 2 years. So when you counsel, you have to counsel that, look, you need to come every month. You need to take the treatment as necessary, and that necessary could be something like 14 injections in 2 years. And if you miss these injections, there is a 50% chance that you will return with the traction detachment, and you may end up with an inoperable eye. This is very important because even in protocol S, some 30 to 40% of patients did not follow up over the entire study period. So don't take monotherapy lightly. Yeah. The better alternative is what was just being discussed, give combination. Combination therapy takes away the risk involved with monotherapy of anti-VEGF. At the same time, it takes away part of the risk involved with the lasers. See why lasers में क्या problem है? Actually, if you look at it, even protocol S could not find vision में कोई difference नहीं है. Okay, let's be very clear. Vision is the same because they took patients with 6/6. Vision कहाँ से कम होना है? तो vision तो DME वाले patients में कम होगा ना. Without DME वाले patients में तो कम नहीं होगा. तो vision is not the issue. The issue is about yeah. So now you have a patient and you want to give him first factoid. In the UK, they found that more than 88% of patients who had had a PRP in both the eyes were able to pass the driving test. So obviously not such a big issue. Secondly, you want to decrease the involvement of the central 30 degrees. Up to arcade is 15 degrees. Normally your laser starts from the arcade. Go 2 disc diameter beyond that and do your laser. And use the anti-VEGF agents to cover the rest. Now after that, if there is some small little neovascularization still persisting, in that small area you can do a direct laser. Your field will be preserved for more than 30 degrees. Your loss will not be there, and you have the advantage of complete regression. And even the PRIDE study actually showed that the chance of maintaining the regression was higher when you did combination therapy.
Sir, can I have some clarification? You said we will do the targeted laser to the area which has a front. But if you look at it, unlike the vascular retinopathies like BRVs where the disease is more localized, this is a systemic disease. So do you suggest, you said no, there is a front that you can restrict your lasers to that.
I said the PRP that you do, instead of going posteriorly, go more anteriorly. After all, where is the ischemia? Anteriorly. So if you have to go by history. Why did the ETDRS do up to the equator? Because the lens we had could only go up to the equator. Today, I'm not going to stop at the equator. Go beyond. Go towards the aura as much as you can, so all your ischemia is covered. Posteriorly, do less. Don't go up to the arcade. Go 2 disc diameter above the arcade and below the arcade. That means you're sparing a 30-degree field in the center. Now you've done all this. Now you do 3 months later a fluorescein angiography, and you find there are some fronts which are there at the posterior edge of your laser. In that localized area, you can do laser after giving an anti-VEGF.
And reverse also, when you have done a reasonably good laser and still some of the new vessels are not regressing, probably an anti-VEGF along combination can help you.
So that's another situation. So once you've done an adequate PRP and you get a persistent neovascularization, that if it is raised, it needs anti-VEGF agents. If it's surface neovascularization, a direct laser can happen. Similarly, as far as the sequence of how to do laser and anti-VEGF, if I have a patient with raised neovascularization, no previous laser, now this patient is at risk of developing a TRD. So here I will first complete my laser, and after that go and give the anti-VEGF agent. Absolutely. On the other hand, if I have small areas of surface neovascularization, I'll give the anti-VEGF agent and quickly complete the laser after that.
Yeah, another thing in which the anti-VEGF adjuncts helps the PRP is that the anti-VEGF, not necessarily one anti-VEGF, maybe 2 or 3 shots of that in these PDR cases, will also reduce the diabetic retinopathy severity score. So chances of NV coming back is lesser if you have used an anti-VEGF adjunct.
But remember one thing, now this is where you have to be very careful. On a clinical examination, the diabetic retinopathy severity score becomes less. But if you do a fluorescein angiography for these patients, the capillary non-perfusion remains the same. That means that time bomb is still there. It doesn't go away. So you should still monitor the patient and if required, do the laser.
But parallelly, there are some studies which show that with anti-VEGF, the retinal non-perfusion areas tend to shrink a bit. There are studies which...
A little bit, but not completely.
Yeah, but your point is well
taken, I would go with Dr. Arnab, sir, regarding the same thing. If you look at, I do treat as a monotherapy in certain selected cases of early PDR, I should say, where you have a single front which is not unlikely to cause much of attraction. We do definitely do a baseline fluorescein angiography to understand the extent of ischemia in this case.
That too
we do
field.
wide field angiography, yes, most importantly. Once you do that, also you do a collage of a OCT angiography. Once you have charted this out, there is not significant traction. We go ahead with anti-VEGF treatment as a monotherapy in certain cases. Which cases? Now these are the people like people from our own profession, our own colleagues from other profession who tend to understand the importance of follow-up. And in these cases, I might not necessarily go with the ranibizumab because it needs every 4 weekly injections. I have jumped on to brolucizumab where I inject about 8 to 10 weekly with a very careful follow-up of 6 weeks. So this is what at the most. But if you see this patient does not understand the importance of coming week, month, weekly back to you, it is
Dangerous.
dangerous.
So,
Yes,
so the key message is, if the patient you feel will not follow up, please don't do monotherapy.
another.
Exactly.
If the patient you're sure will follow up, then do that, and then keep this follow up on a regular basis. And in fact, it's not just the baseline angiography. You need a repeat angiography after
Exactly.
3 to 6 months to see whether it's gone away or
White field
come
that
back
too.
again.
Again, and it should be a white field angiography. It should be done.
And anti-VEGF injections try to avoid if there is lot of fibrosis in the retina.
You
Because a
forget,
lot of- yeah,
not avoid. No,
nahi,
you
we
cannot.
forget, because a lot of medical retina people, they keep injecting in even in cases with lot of fibrous tissue. So this is another point.
May I add one point? I mean,
Of
little
course.
bit, not PDR, but talking of DME. I mean, diabetes as such is a depressing disease. Patients are quite troubled with the manifold systemic issues that they have. So when we advise them injections for diabetic macular edema, obviously initially they're okay. Then that frustration creeps in. That how many more? But I mean, what Dr. Dinesh Talwar so nicely highlighted, and I also quite highlight the same to my patients, is that if we are dealing with your disease aggressively, you control your systemic parameters well, with time the disease will ease out. This is something that we need to highlight, that the first year is your toughest, second year is more or less tough, but third year onwards it will be
So
much better and easier.
It's a carrot and stick.
Yeah.
You do your treatment regularly, the carrot is going to come.
Yeah.
You don't take it regularly, keep taking it.
Right.
I tell them, you don't come, if you don't want to take, you come once in 6 months, once in 4 months, no problem. Every time you come, I'll give you the injection, nothing will happen. It will continue throughout your life. You come to me month after month, take the treatment as required. You may need 6, 7 injections, 8 injections in the first year, but it will go down to 3, 4 injections the next year. It will go down to 1 or 2 injections the year after that. So if you want the treatment to go away, you will need to do regular follow-ups. And it works both ways. You see, what happens is anyone spending so much money on anti-VEGFs also controls his diabetes, also controls his hypertension, also controls the lipid profile, and everything works together to give him a long-term success.
Right.
If I have to add something, the biggest thing we still underspoken about is the hyperlipidemias. This is the most important thing. Control their hyperlipidemias, and you will see a lot of these plaques get over, the hard exudates which are there. Pay equal attention, if not more, to the hyperlipidemias. That's where the whole story would be. Overall, the effective part from the systemic control. And there are a lot of people who are great advocates for diabetics becoming vegan. I'm not a great advocate, I'm not, but it has worked. And there's a big bunch of people, I have colleagues who have converted their diabetic patients into veganism, and their neovascularization has reduced, their dependence on the intravitreals have reduced, the laser has reduced. This is a factual evidence.
Yeah, any form of, see, these are all systemic diseases. We label it as diabetic retinopathy, but we need to understand the play of the other associated systemic disease. So the first step in management, be it of a diabetic macular edema or a diabetic retinopathy, is control of the systemic diseases, call it a form of hypertension, dyslipidemia, the renal conditions, all have to be. Hemoglobin, other thing which we need to take care in our country, especially the rural population. You would be surprised, you are treating with an injection, and you never bother to do a hemoglobin, and later on you realize the hemoglobin was only 7, 6, and you treat him for anemia, and the edema just goes off without even an anti-VEGF. So this is not an uncommon situations in our country. So taking care of the systemic disease is prime and the first step towards any treatment of be it a diabetic macular edema or diabetic retinopathy, I believe.
And that nephrologists are becoming a little more finicky about giving anti-VEGF. I mean, they are against, after one article came a long time back, 5, 6 years back in Kidney International, that it causes worsening of nephropathy status. Recently, I got 1 week back another meta-analysis of studies, and it does not show any change in nephropathy or renal status after anti-VEGF injection. But the ranibizumab is the safest among the anti-VEGF injections. At present, the evidence points to ranibizumab, and it is quite safe. That is what the studies show. especially in diabetic patients, where they may already have a nephropathy. That is absolutely.
So I think we had enough of discussion. Any question from the audience for any one of us? Yes, sir. Please.
We have lots of recurrent CSR in our practice. So, in case of recurrent CSR, what was the treatment schedule, sir?
Actually, sir, there is no evidence of anti-VEGF in CSCR, except in a small percentage where CSCR with PCN, pachychoroid neovasculopathy, is documented by OCTA or some other. So this is actually a spectrum of diseases. CSCR comes on one side, PCV comes on the other side. In between, there is a spectrum with PCN, pachychoroid neovasculopathy. Other than that, there is no evidence of anti-VEGF in CSCR. So this is the current standard. Correct, no, sir?
Yeah, so basically, if you see a patient with CSR who has cystic cavities in the retina, along with the fluid, and some kind of amorphous material, which is inflammatory material, these are the kind of patients, or the patient has a kind of a vascular change on osteangio. These are the patients who may respond, and they respond better not to ranibizumab. This is one group where it's not ranibizumab, it's either aflibercept or brolucizumab which seem to do a better job. But in a normal patient of CSR with only a neurosensory detachment, clean RPE, nothing will work.
Yeah, so on an OCT, you need to look at the retinal pigment epithelial layer integrity and the changes beneath it in the choroidal layers. If you see that to be normal, there is no pachychoroid, there are no big vessels into it, RP integrity is maintained, then it is 100% simple CSR which needs to be managed in a standard way. First line is conservative management, and then the NSAIDs and other. Yeah. So I think we had a good discussion about it. So it's time for me to thank on behalf of all the speakers, Dr. Dinesh Talwar and Dr. Himanshu Mehta, for having wonderful cases and the wonderful lectures they had for all of our audience. Let me also thank my co-moderators, Dr. Arnab and Dr. Mahesh Gopal Krishnan, and last but not the least, the sponsor of the session, the Novartis.